Nyame soma pa na yellow sumia. Let the look be good the plastic. Nyame soma pa na yellow sumia. So mami ya you do not get it. It's a de good pa.
Good afternoon, ladies and gentlemen, and a very warm welcome to this session on triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. We're very happy to see you. We know it's a very hot afternoon, so thank you so much for joining us. As many of us here know, triple elimination has been topical in the last few years, but has become a greater imperative for us as a region. We started years ago with a lot of focus first on HIV, but over the course of time, we've expanded our focus to include syphilis and now hepatitis B. We'll go right into the session, and for this session, we're going to have a presentation, a very quick presentation on the criteria for validation of elimination of mother-to-child transmission. Many of you know that we have had success with 2 countries during in the region, and we will take this opportunity to share and hear from those countries. So right after the presentation, we'll reflect a bit on the data considerations for elimination, path to elimination. We would also hear from Botswana on what they did to achieve the gold tier status, which they had. We will hear from Zimbabwe, which would share on what they are doing to prepare for validation. And we'll hear from Namibia, that is a real success with hepatitis B elimination. So thank you again for joining us. And it's now my pleasure to invite Dr. Moko Newman, who is a member of the Afro-Regional Validation Committee. Join me as we welcome Moko for her presentation.
Thank you very much, Akudo, and good afternoon to everyone here. Thank you again for coming. We are very pleased to have you here to learn, because that's what we are hoping we are going to achieve from this session. You'll be learning about validation. And really, this session aims to highlight our country experiences, like Akudo says, and to have a deeper understanding of validation. And from that, we hope that we'll be able to foster country-to-country learning, which we think is really one of the big aims of ICASA. So first, to start and say that validation itself needs to be looked at as the attestation that a country has successfully met the criteria for elimination, which were set by WHO, for one or more of 3 levels of achievement of path to elimination, or actually having eliminated the transmission, vertical transmission of these 3 conditions. It's really challenging to have this without integration. So a lot of this presentation will talk about that. To set the scene, we'll talk about the validation criteria. Can we have the next slide, please? And even before we start that, triple elimination is an initiative which we have been pushing for a while, like Akudo says, but it's based on synergies between the 3 conditions we are looking at: HIV, syphilis, and hepatitis B. So these synergies need political commitment. We need to look at the fact that the epidemiology of all 3 diseases is highly prevalent in our region especially, and it causes considerate morbidity and mortality, but similar interventions really push the agenda for eliminating the vertical transmission. There has been significant progress, and we note that this can only happen when there's access to quality reproductive, maternal, and child health care services, which are used by all women, children, and their families. Next slide. So we have this integrated approach. That's what triple elimination is all about. And it needs high coverage of comprehensive antenatal services. This is to ensure that there's syphilis treatment, antiviral treatment for HIV, antiviral prophylaxis for hepatitis B, and comprehensive postpartum care for both the child and the child's mother, which includes immunization, which we talked about in the one session we just finished. And the shared features of these three conditions, they enable the integrated systems approach. We always harp on integration. It's important, especially in the current landscape of funding, that we push integration as much as possible and ensure that there's investments into the maternal and child health platform, which all the services for this are provided on that platform. Next slide, please. So, first of all, validation. A country needs to believe it has met all the indicators, and once they have, then the Ministry of Health writes to WHO, and the ministry also convenes a national validation committee. This is the basis of the whole process. The details I will not go on to, but just to say that the National Validation Committee is who is responsible for developing a report. So it's like a program review, and it's a self-review or self-assessment, and you develop a report which is then submitted through the WHO country office to the regional office, and eventually gets to the global level. You can see all the people involved on either side of the slide. Next slide, please. And these are the criteria and targets. Basically, if you leave me to talk to this slide, I'll probably speak for 1.5 hours. So I'll just say that what you need to remember is that there are impact targets and programmatic targets. If we start from the programmatic targets, we need to make sure that our antenatal coverage is good, more than 95%, coverage of testing, and that is for HIV, syphilis, and hepatitis, as well as coverage of treatment, ART for HIV, and also adequate syphilis treatment. It's slightly different for hepatitis because it is based on vaccination, and the vaccination coverage is both for the childhood series and the birth dose, which is what we are focusing on pushing very much now. We also know that we have to push for coverage of maternal hepatitis testing, and from that, antivirals for those eligible, prophylaxis for those who need that, and treatment for those who may need that. Next slide, please. So the path to elimination is what many countries in our region focus on. A country has to be eligible for this because many of these countries have such a high background prevalence of HIV, syphilis, and hepatitis B that it's almost impossible for them to get to those very stringent targets we talked about in the previous slide. Once a country has a maternal prevalence of more than 2% for HIV and more than 1% for syphilis, they are eligible for the path to elimination rather than actually getting to elimination of vertical transmission. For hepatitis B, we look at the estimated prevalence of the surface antigen in 5-year-olds, and this needs to be less than 1%, or in the general population, more than 1%, or more than 5% in the general population to qualify for this criteria. Next slide, please. So the process for being validated on path to elimination, it's important to note that it's the same process as when you are doing for elimination. Same tools are used, assessment. We use the same mother-to-child transmission rate of 5% for the impact criteria, which we know has to be met for both elimination and path to elimination. The difference is the infant case rates for syphilis and HIV, where for the gold, silver, and bronze tiers, you're allowed to have certain levels put up there from 50, more than 50, from 250 to 750 per number of live births. The process criteria are also different. If you remember in the previous slide, we were talking about 95, but for path to elimination, we stick to 90, except for the gold when we get to squares show what happens for hepatitis. And as you can see, the vaccination, 90% coverage for both the treatment, Hep 3, as well as birth dose. And then this is for the bronze. For the silver, it's a little more because we ask in addition for more than 50% coverage of the timely birth dose. Whereas for the bronze, all we need to have is the policy in place. Then for the gold, we need to have the same 90%, but with the implementation of the birth dose, I've put it in the wrong way. The gold should have been on that side and then bronze on this side. But just to say that it's slightly less stringent for path to elimination. Next slide, please. So we have guidance, we have tools, we have templates, and this is what is the source of the documentation that is needed for the assessment. For HIV, we know that the information is found in the AIDS control programs, it's found in the AIDS Commission. For syphilis, a lot of the time is found in the reproductive health, but it's also in the National AIDS Control Program because many of them are AIDS and STI control programs. For hepatitis B, the documentation comes from the immunization program. So if we are not friends with the immunization program, we will not get there. We really need to talk to each other. Programs, immunization, and most importantly, MCH. A lot of the data is there. Antenatal coverage, testing coverage, all that is on the MCH platform. And it's important that we get the MCH to own this process, the validation process. So the services and access information comes from this platform. And we also know that apart from antenatal care, we need to look at postnatal care because we are looking at the mother and the child. And then for the disease program, like we said, is HIV, STI, and viral hepatitis programs. For labs, we need to look at quality, reliability, and accessibility. For data, we need to think of public-private because many people do attend the private sector. And if you're looking at within the confines of a country, it's both public and private data which is needed. And then lastly, but not the least, we need to look at human rights, gender equality, and community engagement to make sure that all these services are being delivered in a manner which is commensurate with basic human rights. Next slide. So that in a nutshell is what we are looking at before we look at the reports: programs and services, laboratory services, surveillance data evaluation, and then human rights. And on the left, you can see the documents which is available. But all this is available online, and we have the URL at the bottom. Next slide, please. Beyond the indicators, the process indicator targets should have been in place for 2 years before a country can apply, and the impact for a year. All the areas within the country need to demonstrate effort and success. Even if the national value is good, the low-performing subnational administrative units should be shown, and you should show that they are not unattended. Then the country needs to have an adequate M&E and laboratory system to include the private sector, which gives us that information. And lastly, like I said, the criteria should be met in a manner which is commensurate. So next slide, please. I think that's the last slide. Yes. So having this background, we have a panel discussion looking at what has happened in our region. And we are going to be looking at innovations for service delivery. And we have 3 panelists here with us and 1 online. And I would like to ask specific questions from each panelist for them to speak. Probably we will give each panelist the opportunity to introduce themselves, just say your name, who you work with, so we don't take up too much time. And we'll start with a question on the considerations for data and would ask Safika Saji from UNICEF to speak to that. Thank you.
Thank you very much, Mokor. It's great to see you up on the podium. You're a much beloved colleague, and it's been a privilege to work with you for so many years. I'm Shafiq Isaji from UNICEF. So data for validation really is at the core of the validation process. As Mokor described, the criteria for validation include a set of what we might think of as outcome or impact indicators, such as the MTCT rate, the Hep B surface antigen prevalence in under fives, the pediatric case rates for HIV and syphilis, but also a set of process or program indicators. These include coverage of ANC services, coverage of testing services, and coverage of treatment services for HIV, syphilis, and Hep B. But really beyond these quantitative elements, there are also a set of qualitative criteria. And my point about this is that all of them require data. Clearly, you need data systems to be able to reliably report on your initial impact indicators. That's the first benchmark that you have to achieve if you want to apply for validation. But the qualitative criteria, including showing that your least well-performing district is also meeting the criteria required, including showing that you have done the work in a way that protects the dignity and rights of women living with HIV, women with syphilis, women with hepatitis B, and including showing that your M&E systems are robust, link the public and private sectors, and are able to reliably pick up any cases of transmission. That means infant testing and infant follow-up to be able to detect those cases that might have gotten through your safety net. So throughout the process, data lies at the core of what you need to show in order to be able to apply for validation. That's the first point that I want to make. The second point is that I think an area that we have not looked at enough in this space is community-led monitoring. CLM identifies service delivery gaps and enables local providers to work with their community partners on identifying local solutions to address those service delivery gaps. So this is upstream of the validation process, but it's really necessary to make sure that you're doing things in the right way that will eventually lead to you achieving the outcomes that are necessary for us submitting for validation. Of course, CLM is also important at the national level and with policymakers in order to improve the quality of services and the ways in which women are getting access to high quality, dignified care that respects their time, that respects their agency, and that respects their choices as clients coming for antenatal services. Now, this forum doesn't allow us for talking too much about ways of community-led monitoring, but there's a plethora of resources out there, including materials that have been produced by the International AIDS Society, by FHI 360, by UNAIDS, and by other US government partners that speak to the ways in which community-led monitoring can be used in antenatal care settings. And I think it's a very important area of work that we need to expand upon. And finally, let me say that we're here talking about validation. And we salute Botswana, Namibia, and Zimbabwe, which is approaching that threshold. It's taken a huge amount of work to get there. But data is not just important for validation. Data is essential for countries that are far from validation. If you are in a Nigeria or other countries in this region where coverage rates are much lower, you need that data in order to be able to inform the way in which you modify your programs to address the challenges that are resulting in a lack of access, a lack of coverage, and a lack of achievement of the indicators that you want to see moving in the right direction. So data is not just a nice thing to have or something that you quickly put in place when you're applying for validation. Data is essential to getting to the place where you are even in a position to be able to apply for validation. And I think that's an important message. Sometimes in the hub of validation, we forget that there are many countries that still need basic PMTCT programming support. And especially as we've expanded to a triple elimination platform with the newly relaunched triple elimination country guidance for planning how countries can get to elimination of HIV, syphilis, and Hep B, the data piece is essential to inform and understand how we're doing it. So let me close by saying, if you didn't measure it, if you didn't record it, and if you didn't report it, it didn't happen. And while I have the mic, I just want to tell us that unfortunately, the US has decided to abandon its policy of universal hepatitis B birth dose just a few days ago. So this is tragic news because it might influence the way in which US government funding supports our own efforts to achieve Hep B vertical transmission elimination on the continent. Our work gets more challenging, but our resolve does not change. Thank you very much.
Thank you, Shafiq. Very important points. And we'll next call Lynn. Now, Lynn is going to tell us about one of our very proud moments, because not only did Botswana get validated, they have moved from silver to gold. So well done, Botswana. And we'll ask you to give us the program experience on how you did the movement. Thank you.
Thank you very much. So Botswana is very proud to be the first high-burden country to have achieved the WHO Gold tier status for HIV. And this really was achieved through lots of hard work, lots of commitment, and a comprehensive and integrated strategy. Some of the highlights of this strategy really is governance and leadership. Botswana is well known for its political will and commitment towards HIV care. HIV care in Botswana is not like any other program in Botswana, and therefore that really owes to the foundational leadership and commitment of the government. Secondly, we looked at service delivery modules to ensure that there's much improvement in PMTCT care and EMTCT now in the 3 diseases. So we tried, we succeeded in scaling up HIV testing. So in our guidelines currently towards pregnancy and breastfeeding women, we test them every 3 months. This is to ensure that we pick up the infection early and then treat them early, also link them to PrEP. Integrating HIV testing and syphilis testing is one of the things that we think that really led to the successes in ANC services. I'm sure most people know that Botswana ANC coverage is always above 95% coverage. So it's one of the things that really worked for us. Also expanding access to ART. We utilize the treat all strategy. ART is free in Botswana, and therefore everyone is able to access ART, the citizens as well as the non-citizens. So expanding access to ART was one of our pillars, including laboratory strengthening. So in Botswana, we use the spoke and hub model for laboratory. So EID monitoring, strengthening EID testing, making sure that people are followed up. We use EID champions, mentor mothers to ensure that people come for testing or are reminded for testing. So it's one of the things that really helped us to ensure that mothers are tested, as well as viral load monitoring. CQI projects, I think they really contributed a lot in different districts and facilities to ensure that people who had problems in implementing the guideline were able to improve themselves. It goes without saying that health workforce capacity is quite important. Cascading the guidelines, ensuring that they are implemented well is one of the things that led us to the success. We have a dedicated EMTCT team at the Ministry of Health, and we also use the model of PMTCT or EMTCT focal persons in every district who ensure that guidelines are adhered to, tools are, monitoring tools are filled appropriately. In terms of community engagement, this is one of the key points in terms of succeeding. A lot of education has to go out to the public, has to go out to the healthcare workers. And also because of human rights, we have to ensure that the healthcare workers are doing exactly what they need to be doing. So we had a lot of CSO engagement who helped us in this, all our partners ensuring that services are delivered, education is delivered to the community, and they went out into the community educating people on human rights and ensuring that services are done quite appropriately. We could not have succeeded had it not been for the technical and financial support of all the partners that we have in Botswana. We really thank them, and even in the light of dwindling funding, we do appreciate their work that they did. But every success is not without challenges. We had great challenges in terms of data. We use a lot of manual systems, and that was one of our issues. However, the only advantage we have as Botswana, because we are relatively small, we were able to do DQA, data quality assessments across the country to ensure that our data is good and validated. But it's one of the improvements that we need to do. And we also really need to improve in the other two diseases. I'm sure we also want to get some certification in syphilis and hepatitis. Thank you.
Thank you, Lynn, but you didn't tell us who you are.
Sorry about that. So my name is Dr. Lynn Shirare. I am the public health physician in the Ministry of Health in the HIV division.
Thank you so much, Lynn. So while we are still championing Botswana, who has gotten there, we will next speak to a country who is on its way. Like Shafiq says, it's important, even if you're not there, to really keep track. So we'll call on Angela, the next speaker. She will introduce herself and then talk to us about the pre-application and early planning for application for validation. Angela, over.
Thank you very much, Moko, for the invitation to speak in this session. My name is Dr. Angela Mushavi from Zimbabwe, Ministry of Health, and I coordinate PMTCT and pediatric HIV care and treatment. I'm very glad because the first thing that I was going to say in terms of our country preparedness is that we've got very high political leadership within our country, which is invested in health and the health of women and children. In preparation for the validation, almost 8 years ago, we constituted a national validation committee on EMTCT. And that time, we were speaking to dual elimination of HIV and syphilis. And I'm very happy that in the audience, we have our first chair of the National Validation Committee in Zimbabwe, who was our minister back then, Dr. Parire Nyatwa. Thank you very much for being here. I know that our current minister, Dr. Mombeshora, is here. He was unfortunately delayed and may not actually be in the room at this point. So one of the key things that I believe we need to actually push us towards validation as a country is to have this political leadership. It is to have the resources and the governance to actually steer the ship and make sure that it happens. We do have a national validation committee, but we also have a sub-national provincial validation committee. And this realization really was, you can do so much at the national level, but when you look at the sub-national or the regions, as some countries call them, we have provincial level leadership, the provincial medical directors.
And we find that in our context, challenges in one province may not be exactly the same as challenges in the next province. And that's why subnational leadership is key. And so we have constituted in our country provincial validation committees to make sure that no place in Zimbabwe is left behind. So they take charge of implementation within their province. And then we meet every quarter as the National Validation Committee together with the provincial leadership. And we think that's really helping us to move the needle in terms of not leaving any hotspots. I think you mentioned about blind hotspots, Moko. We also, right at the beginning of the NVC, worked with WHO and UNICEF, and we were able to get our National Validation Committee trained. So they actually came to Zimbabwe, I remember, from Geneva, from Afro, and they trained our team so that we were very familiar with the tools, and we were also very familiar with the reporting that is required. Because we have to achieve our targets in a human-centric and human-centered, human rights way, we have a lot of representation of civil society within the National Validation Committee. So we've got gender experts, we've got lawyers in the National Validation Committee as well as the Provincial Validation Committee. We've got women living with HIV, young people living with HIV, and we also have the networks, the Zimbabwe National Network for People Living with HIV, sitting within the National Validation Committee. And that's really helped. So the capacity building was not just for us in health, it was for that multi-sectoral team that involves a lot of civil society and gender experts as well as human rights experts. And I want to mention that as we are moving towards attaining the actual indicators, as you have heard, impact targets, the process targets, we have had to do like a baseline assessment. Exactly where are we based on the 4 tools that you shared, Moko? So we have identified our gaps. We know exactly where we need to go. And I think in the next few years, if I might say, Zimbabwe will be applying for the gold tier on the path to elimination of vertical transmission of all 3 diseases. Thank you very much.
Thank you very much, Angela. Very exciting. There's always so much action going on in Zimbabwe. Our next speaker is online, and I hope we have her. We haven't got her yet. Okay, she was from Namibia, Naomi Shopola, and honestly, that is political commitment. She is the real person pushing in Namibia who has been able to get Namibia to, first of all, apply for triple elimination. Namibia was the first country in the world to apply for all 3. Although they only got for 2, that's hepatitis and HIV, we know that they are really ready and pushing. Syphilis has always been a problem in all the countries, and it's really important that we highlight our syphilis data. Syphilis is such an old disease, we have no reason not to have stopped congenital syphilis by now. And yet, we don't even have the data to say exactly where we are. We only have estimates, and countries have been working on syphilis forever. The MNCH platform has been working on eliminating congenital syphilis for many years. We don't have enough investment into that, and our data does not help us much. It would have been wonderful to hear from Naomi, because we really wanted to hear the program experiences and gaps that hindered triple elimination in Namibia, and especially she would have spoken to syphilis. But if we haven't been able to get it, maybe while we still try, we'll go on to our questions. And if we do get her, we'll ask her to speak. So I'll hand over to Akudo to start off the session. Thank you.
Thank you so very much. Shall we again acknowledge the panelists for interventions. Thank you so much. Um, while we wait for or hope that Naomi can join us, we will just go ahead with a few questions and we would like to open the floor now for questions. Please indicate if you have any questions and indicate who your question is directed to. Introduce yourself very briefly and we can take it. So the first question, please. Can you hand her the mic? Thank you.
Thank you. Hello, everyone. My name is Rosemary Njogu. I come from Kenya. I work with Japaigo in Kenya, but also as a regional advisor, so cover Africa. I'm so thrilled and very happy to see Botswana and Zimbabwe, or Zim as we call it, sitting in front telling us what they have done. I have first to appreciate the countries and also mention on Botswana. I have a question for understanding. I'm here to learn for the sake of other Africa. For when it comes to testing, you mentioned that you do testing after every 3 months. Does that apply to the private sector? For the mothers, ANC mothers going to the private sector, how are you managing the cost out of pocket as pertains to that? Then I really love the mentor mother model because this is a model I worked with earlier in my career. Has the government taken it up in Botswana? Is the government now paying stipend or appreciation when it comes to the mentor mothers? And to my other 2 questions, but small ones, kindly unpack for us, by the time you're getting your application, where was your coverage, ANC coverage and coverage for testing for syphilis? That would really help us as we continue. And to the chair of the panel today, I would really want us one day to have a conversation on the syphilis, why we're not achieving coverage, good coverage for syphilis and testing. Thank you.
Thank you. Thank you for those questions. And we'll take one more and then give the panelists a chance.
Hello, good afternoon. My name is Ruth Ninsima. I work with the International Community of Women living with HIV Eastern Africa. We are in Uganda. First of all, I want to recognize and thank Gavi, if we have any Gavi representatives here. Last week, we received over 164 doses of hepatitis B dose, birth dose, and but there is still some big gap. First of all, there is a lot of information gap about hepatitis B. Like, it is so quiet. Yes, as communities, we've taken on some triple elimination projects like the one I ran, but the burden is too big. You go into a community and someone has never heard of hepatitis B. Then at facility level, even the doctors themselves, they don't know how to manage. At some facility level, they can only test. And once you're positive, they only refer you to the next. So there is a lot of gap. I wonder at what level Uganda is in terms of validation, in terms of application. Have we applied also for that triple elimination certificate? And if it is, where are we and how would you advise us to move? I sit on the hepatitis B committee for the technical working group of the Ministry of Health, but these are things that keep coming in and they're not resolved. Thank you.
Thank you so much. So before we take further questions, we'll get responses. And I'm going to ask, before we turn to the panelists, for Dr. Fumileshi to comment. What is changed with hepatitis B guidance from WHO? and how can some of those concerns be addressed, because those are reflected in some of the new direction of the guidance. Can we please pass the mic to her?
Thank you very much. You're from Uganda? Great. I was in Uganda about 4 years ago, and I must tell you that Uganda is the only country in Africa that started a nationwide screening for viral hepatitis. And in Uganda, which is our model country, nearly 40% of the population were screened for viral hepatitis. So I'm completely surprised if any Ugandan does not recognize viral hepatitis. In Uganda, not only did they screen the adult population, they also started vaccination of adults. So that was a big step forward. And we're so proud and happy that a few days ago, Gavi has delivered hepatitis B birth dose. We're excited because the burden of hepatitis B in Uganda is very high. And you know what, you're right, it's possible that in the next few years, Uganda will be applying for hepatitis triple elimination. Now, the newest guidelines you talked about, apart from the hepatitis B birth dose and the childhood vaccination in children ages from 6 weeks to 10 weeks to 14 weeks, we now have new guidelines that suggest that mothers must be tested and antiviral prophylaxis with tenofovir given to women who are hepatitis B positive. This also strengthens prevention. And I must say that Malawi is also the first country in our region that has embarked on a nationwide universal prophylaxis for pregnant women. I hope that answered the question. I must tell you that Uganda is on the way, not just for hepatitis B, PMTCT, but the complete package of hepatitis B response. I hope I answered your question.
Thank you. And just note that you have been recorded, and you will need to make good any promise that you have made. Thank you. So,
So just to add on, and to Uganda, not only are you first, you were one of the first countries who had their NVC constituted and trained about 10 years ago. The only problem was that your mother-to-child transmission rate was above 5%. So you are moving. I don't think that there's too much of a problem there. Once the mother-to-child transmission rate comes down to 5% or less, you'll be there. The data is there. You're doing well.
thank you. Thank you so much. So we'll turn now to Botswana. Botswana, if you can respond to the question to you.
I got them. Thank you so much for the questions. The first question was about the application of our guidelines to private practice. I did mention that HIV programming in Botswana is not like any other program in the Ministry of Health. So we have a national guideline committee. So the guidelines for HIV in Ministry of Health, they are an umbrella for private sector and for government. The gap that we might have might be the data, but because in public service, all HIV care is free, the majority and bulk of the population goes to public health. And the private sectors report, depending on which district they are in, they report through the DHMT models. So then what we might have a gap in is segregating who is private and who is public, because they report through the same channels. The second question was about adoption of mentor mothers, the government, which is a good pertinent question because most of the mentor mother model is a partner funded model. So in Botswana, the government is moving towards what we call integrated primary healthcare models. We are trying to move away from the siloed programming where we have a TB mentor, an ART mentor, and a mentor mother. So we have what we call community healthcare workers, where we are hoping to integrate these siloed models into this one cadre. We are just starting off, but we are hoping that we are not going to lose the gains and the benefits that we had from having mentor mothers, EID champions, and so forth. Thank you.
Thank you so much. And question on syphilis. Maybe I would allow Dr. Mushavi, to reflect a little bit briefly on syphilis, since you're thinking about going forward with syphilis. Yes. And then I'll also ask Shafiq thereafter to reflect very briefly, specifically on syphilis data.
Yeah, thank you very much. In fact, because of the limitations of time, we would not be able to present our data. But some few months ago, we've actually been approached to work our way towards application for bronze tier for syphilis. So we are one of the countries that is actually doing very well in terms of syphilis programming. I must say, before we introduce the HIV dual test kits, we tended to do very well in terms of testing for HIV in the regions of 98% testing for HIV. But we've introduced the dual test kit, and since we introduced the dual test kits, the testing for HIV and syphilis is almost neck and neck. So we are doing very well in terms of testing. Even treatment, last year, our treatment for syphilis was sitting at 93% for those mothers that test syphilis positive. So I'm very happy with the progress that we are making, and I think we just need to strengthen that. It's the same story also for the hepatitis. Currently, we use the dual test kits for HIV and syphilis, and then we take a separate test kit for the hepatitis B. But we are preparing for adoption of the combo kit that will allow us to test all three diseases with one prick. So that's one of the steps that we found really helped us to bridge the gap between HIV testing and syphilis testing. And in the last 2 years, we have not had shortages of benzathine penicillin for treatment of syphilis for the prevention of congenital syphilis. So there's a lot of good progress that we are making, and I think we are not very far from applying. Maybe we should just start with syphilis and see everything else come together. Yeah, thank you.
Thanks for already answering my question.
Thank you so much. We're over time. So let me say that congenital syphilis is the tip of the iceberg of a global syphilis epidemic that is rising. The good news is that people are beginning to pay serious attention to this. First of all, the benzathine penicillin access challenges of yesteryear have been addressed by the approval by WHO of a number of additional benzathine penicillin manufacturers that are finally easing some of the blockages around supply chain for benzathine penicillin. And that's a really important fact. Dual tests, certainly, triple tests, certainly, and there are new tests coming that will test actually for the non-treponemal testing for syphilis as a rapid test, which I think will significantly improve our ability to interpret syphilis tests. There's a lot of provider confusion out there about what a positive syphilis test means even. So I think things are shifting with the new emphasis from Gates that is putting a lot of attention and focus on syphilis, thanks to some GVAC champions that are now really working closely with Gates to ensure that this rises to the top of the Gates agenda as a global issue that needs funding, attention, and improvement, not just for congenital syphilis, but more broadly.
Thank you very much. And Shafiq has reminded us that we're out of time. So if there's no burning question, I think we can round off this session. A burning question, please go ahead.
Very simply, It's a plea to you. I agree with her. I've done research with Ugandans, Zambians, Malawians, Botswana, South Africa, leading protocols. In fact, one of our protocols where we discovered that Uganda had the highest prevalence of syphilis is a study called VOICE, where we're testing tenofovir because of its effect on. And the thing I want to bring to your attention is what she said. Pardon me? Oh, my name is Mike Ranger, University of Zimbabwe.